Now we are going to start portal hypertension. So what is the normal portal pressure? Normal portal pressure is 5 to 10 mmHg or 10 to 15 centimeter saline. So first, what is the normal portal pressure? Normal portal pressure is 5 to 10 mmHg. And the second question, which is asked in the form of saline, and that is 10 to 15 centimeter saline. Right? So if the normal portal pressure is 5 to 10 mmHg, what is the definition of portal hypertension? So portal pressure more than 10. So definition of portal hypertension. So in portal hypertension, the pressure is more than 10 mmHg. Okay, there are two universal manifestations of portal hypertension. What are those two universal manifestations? One is esophageal varices, so variceal formation, and second is splenomegaly. So what are the universal manifestations? Means seen in all patients. Universal manifestations of portal hypertension. First is variceal formation or varices, and second is splenomegaly. Splenomegaly. Clear? So simple question, at what pressure esophageal variceal formation begins? So in patient of portal hypertension, there will be esophageal varices. So at what pressure it begins? It begins at pressure more than 10 mmHg. So esophageal variceal formation begins when the pressure is more than 10, and variceal bleeding occurs when the pressure is more than 12 mmHg. So varices, so variceal formation begins when the pressure is more than 10 mmHg, and variceal bleeding is seen. Variceal bleeding is seen when the pressure is more than 12 mmHg. So read the question carefully because both of these questions are asked frequently. If we see the causes of portal hypertension, what is the most common cause of portal hypertension worldwide? That is cirrhosis. And if you're talking about children, because the most common cause of cirrhosis is generally alcohol, and children are not allowed to buy alcohol. So in children, what is the most common cause? It is EHPVO, extrahepatic portal venous obstruction. So if you see the causes of portal hypertension, worldwide most common cause cirrhosis. So overall most common cause is cirrhosis. And in children, what is the most common cause? In children, it is EHPVO. This question was asked in AIIMS. Clear? Now what is the cause of hypertension? Means increased pressure. So see, there are two causes. Either there is increased flow in the vessel or there is increased resistance. Okay, so if you are talking about cirrhosis, see, in portal hypertension there is increased resistance. So it can be because of increased resistance or it can be because of increased flow in the vessel. Now see the example, it's very easy to understand. If you see, this is liver, this is portal vein. Now these are intrahepatic branches of portal vein. Clear? Intrahepatic branches. Patient is having cirrhosis, and you know that in cirrhosis there is formation of regenerative nodules. So see, there is formation of regenerative nodules. Okay, and these regenerative nodules are going to compress the intrahepatic branches, and because of this compression, what will happen? There is increased resistance in the vessel, leading to what? Portal hypertension. Lots of questions are asked related to etiology of portal hypertension, but before that you should understand that what is the normal anatomy. So what is the etiology? It can be pre-sinusoidal, sinusoidal, post-sinusoidal, intrahepatic, extrahepatic. So to understand this, just have a look of this simple anatomy. Now see this diagram. This is central vein, okay, and this is portal triad. Can you see? This is central vein and this is portal triad. right? In this portal triad, you can see that this is portal vein, this is bile duct, and this is a branch of hepatic artery, right? Now see, the blood from portal vein is going into sinusoid, and the blood from hepatic artery is also going into sinusoid. And what happens in the sinusoid, there is actual mixing of blood here. Actual mixing of blood is going to occur, and finally it is going to drain into central vein. Here you can see that this is the bile canaliculi, so the bile is going to drain into the bile duct. This is the simple anatomy. Now just focus on this, that this is sinusoid. Okay, so any etiology of portal hypertension before sinusoid is pre-sinusoidal, after sinusoid is post-sinusoidal, and if it is in the liver, it is intrahepatic, and if it is outside liver, it is extrahepatic. Okay, see the diagram. So this is liver, this is the portal vein, this is the spleen. Okay, and here we discussed that this is the portal vein, one of the branch. This is the central vein. From portal vein, blood goes into central vein. Clear? There was bile duct. There was a branch of hepatic artery, and mixing of blood was occurring. Mixing of blood was occurring in this area, and that is known as sinusoid. So in sinusoid, actual mixing of blood is going to occur. Clear? Now whatever the causes before this sinusoid is pre-sinusoidal, after this sinusoid is post-sinusoidal, and around or within the sinusoid is sinusoidal, right? Now imagine there is a condition known as splenic AV fistula. Splenic AV fistula means splenic arteriovenous fistula. So arterial blood is going into the vein, and because of this there is increased flow. So this is leading to portal hypertension. So this is pre-sinusoidal or post-sinusoidal. So you can make out that this is pre-sinusoidal, and this is intrahepatic or extrahepatic? Extrahepatic. Similarly, splenic vein thrombosis or splenomegaly, all these are pre-sinusoidal and extrahepatic causes. Clear? So see, all these are pre-sinusoidal and extrahepatic causes. Clear? So this includes first splenic AV fistula, splenic AV fistula. Second, splenic vein thrombosis. If there is splenic vein thrombosis, and splenomegaly. Clear? Now see the another cause. If there is deposition of eggs of cystosoma here there is deposition of eggs of cystosoma. So in cases of cystosomiasis also there is portal hypertension, and if this is the location of deposition of eggs, what is the cause? This is pre-sinusoidal and intrahepatic, and you must be knowing that cystosomiasis is the most common cause of pre-sinusoidal intrahepatic portal hypertension. Okay, so this is pre-sinusoidal intrahepatic, right? What are the causes? Most common causes cystosomiasis. Cystosomiasis. This was asked many times. So this is most common. Similar to cystosomiasis, in sarcoidosis also similar problem occurs, right? So second is sarcoidosis. Nodular regenerative hyperplasia and graft versus host disease. Nodular regenerative hyperplasia and graft versus host disease. Clear? Now coming to the sinusoid, right? So around this sinusoid, if some etiology is there, that is sinusoidal, and that includes causes of cirrhosis. So what is the most common cause? Alcohol. Other causes: hepatitis B virus, hepatitis C virus infection, primary biliary cirrhosis, primary sclerosing cholangitis, right? So see, what are the sinusoidal causes? In the sinusoidal causes, the causes of cirrhosis are included. Clear? So what are those causes? Alcohol, hepatitis B virus infection, hepatitis C virus, primary biliary cirrhosis, primary sclerosing cholangitis, right? Now, post-sinusoidal intrahepatic cause, and that is single cause, and that includes VOD, veno-occlusive disease, right? So what is post-sinusoidal? Post-sinusoidal, okay, intrahepatic, and that is single cause, that includes veno-occlusive disease, right? And if you are talking about post-sinusoidal extrahepatic, so that includes what? Budd-Chiari syndrome, right-sided heart failure, IVC obstruction, and constrictive pericarditis. So post-sinusoidal extrahepatic cause, post-sinusoidal extrahepatic cause, this includes Budd-Chiari syndrome, IVC obstruction, right-sided heart failure, and constrictive pericarditis. Constrictive pericarditis. Clear? So if you remember this image, you can easily crack any MCQ related to etiology. So we discussed that in cases of hypertension, either there is increased flow or there is increased resistance, right? So question is asked that what is the investigation of choice for diagnosis of portal hypertension? Before discussing the investigation, I want to tell you the basic concept between ultrasound, Doppler and duplex, related to ultrasound, Doppler and duplex. Okay, students are having confusion. So generally ultrasound is used for anatomical delineation or for anatomy, and we go for Doppler, and this is to estimate the flow. So when we have to assess the flow, we go for Doppler, and when we want investigation for anatomical delineation, we go for ultrasound. Now what is duplex? On the roadside, you have seen many duplexes. In the duplex, what happens? In duplex, there is a ground floor and there is a first floor. There is ground floor and there is first floor. So generally in ground floor, ultrasound, and in first floor, there is Doppler, right? So the investigation is known as duplex, in which there is ultrasound and Doppler, both are used, right? Now imagine if I want to assess only flow, I go for Doppler. If I want to go for anatomical delineation, I just go for what? Ultrasound. But if I want to assess the anatomy as well as the flow, I go for duplex, right? Now let's discuss it with example. In portal hypertension, in some of the cases there is increased flow, so you want to assess the flow. What is the investigation of choice? Doppler. In cases of testicular torsion, what happens? The flow of testis, vascular flow is decreased, so what? You have to go for Doppler. In cases of varicocele, when there is a network of veins around testis, you want to assess the flow. Investigation of choice for diagnosis is what? Doppler. Now see, if we want to see or diagnose the varicose vein, in varicose vein what we want to see? Whether long saphenous vein is affected or short saphenous system is involved, what is the status of perforators, what is the location, whether the patient is having DVT or not. So to assess all these, what you need? You need duplex. Suppose we want to diagnose the DVT. In DVT, we have to see that whether flow is increased or decreased, what is the location of thrombus, and anatomy. So in DVT as well as in varicose vein, we need what? Duplex. Clear? So see, Doppler. Doppler is investigation of choice for diagnosis of first portal hypertension, okay, second testicular torsion, and third varicocele. Simple. Next is duplex. And duplex is investigation of choice for, this is investigation of choice for diagnosis of, we discussed, very important, varicose vein, varicose vein and deep venous thrombosis, DVT. Clear? So investigation of choice for diagnosis of portal hypertension is what? Doppler. Questions are asked related to portosystemic anastomotic sites. Why? Because there is formation of collaterals at portosystemic anastomotic sites. And what happens? Via these collaterals, the blood from portal vein enters into systemic circulation via these collaterals. The three main locations of these collaterals, first is what? The GE junction, right, or lower part of esophagus. So around GE junction, you can see that there is azygous vein. Clear? This is a systemic vein. We discussed that azygous vein and hemiazygous drains the esophagus, and here you can see this is the left gastric vein, also known as coronary vein. Now you can see that there is portosystemic anastomosis around G junction, and that leads to formation of what? Esophageal varices. Clear? Now see this second location. This is internal hemorrhoids. Actually there is formation of what? Rectal varices. Rectal varices. Now in this location there is portosystemic anastomotic site between which veins? Here you can see this is superior rectal vein, and if you see this superior rectal vein, it's a tributary of which one? Inferior mesenteric vein. And you know inferior mesenteric vein drains into splenic vein, and then further the blood goes into portal vein. Clear? Now see, this is inferior rectal vein. Here middle rectal vein is not shown. So superior rectal vein and middle and inferior rectal vein, this is having portosystemic anastomosis. Here you can see that this inferior rectal vein drains into internal iliac. Internal iliac, external iliac joints form common iliac, and common iliac, both common iliac joints and form IVC. Got it? So second location is what? In the rectum or near rectum and anal canal, right? And this is internal hemorrhoid or rectal varices. And third is, this is caput medusae. How caput medusae looks like? So here you can see around umbilicus, this is the collaterals. Clear? And it looks like this. So this is caput medusae, right? Now see here, in or around umbilicus there is portosystemic anastomosis between the paraumbilical vein. It's between paraumbilical vein and superior and inferior epigastric vein, also known as superficial abdominal veins. Clear? So this is known as what? Caput medusae. These are the three very important locations. Now see the question which is asked. Suppose I am putting my stethoscope around umbilicus. At the location of caput medusae, I can hear venous hum. And what is the name of this murmur? This is known as Kruellheier-Baumgarten murmur. So what is that? Audible venous hum around umbilicus. That's known as Kruellheier-Baumgarten murmur. So this is audible venous hum around umbilicus. Clear? So these are the important points related to portosystemic anastomosis. And the most important is what? Esophageal varices. So we are going to discuss in detail what's the location and from which location the maximum bleeding occurs. So in patients of cirrhosis, generally most common cause of portal hypertension worldwide is cirrhosis. What is the most common cause of death in cirrhosis? In cirrhosis there is esophageal variceal bleeding, but the most common cause of death is hepatic failure. Second most common cause of death is what? Variceal bleeding. So first question, that in cirrhosis, what is the most common cause of death? So most common cause of death in cirrhosis. This is important, and here students make mistake. It is the hepatic failure. Hepatic failure followed by variceal bleeding. Okay. Now, exactly from which place maximum risk of variceal bleeding is there? Now see, this is esophagus, this is stomach. So it's the lower 3 centimeter of esophagus. So it's the lower 3 centimeter of esophagus. From this area, what? there is maximum risk of bleeding. What is varices? Varices are nothing. These are the, yes, collaterals, venous collaterals. How it looks on endoscopy? So now see, this is how it looks on endoscopy, right? And whenever the bleeding starts, generally it occurs from the lower 3 centimeter. Whenever the bleeding starts, it's arterial or venous, it's the venous bleeding. This venous bleeding, yes, the venous blood, it is going to collect where? In the stomach. And in stomach there is already presence of what? Acid. So acid works on the blood and the color of blood converts into coffee colored. So whenever 300 ml, 400 ml blood is collected into the stomach, it is going to irritate the stomach and patient is going to vomit the clotted blood, which is coffee colored. Now see, in one episode of bleeding or hematemesis, 200 to 300 ml of blood is coming, and these patients are having 4 to 5 episodes of hematemesis. So if the patients are having 4 to 5 episodes of hematemesis and the patient is brought to your emergency, what is the problem? Majority of patients are in the state of shock. Clear? So if the patient is in the state of shock and brought to your emergency, after maintaining airway, breathing and circulation, what we have to do? Put 2 large IV bore cannula and start IV fluids. Clear? What is the fluid of choice? Ringer lactate. So see how we are going to manage the patient of varicose bleeding. So management of varicose bleeding. Since most of the patients are in the state of shock, after airway, breathing, circulation, what? Put 2 large bore IV cannula. 2 large bore IV cannula, and generally which one we prefer? Green cannula. Start IV fluids. What is the fluid of choice? Fluid of choice is Ringer lactate. Clear? Now what is the cutoff blood pressure which we have to maintain in these patients? The cutoff blood pressure which we are supposed to maintain is 100 mmHg, not 120. Systolic 100 mmHg we have to maintain. And how much hemoglobin? 8 gram%. Why not more than 100? The cutoff is 100 and hemoglobin is 8. If we give excess amount of fluid or blood, what happens? The collaterals are over distended and it further increases the risk of bleeding. Okay, so what's the target blood pressure? Systolic 100 mmHg and 8 gram%. Okay, question is asked that what is the target hemoglobin in general? So generally we have to maintain 10 gram% in surgery, but here it's the 8 gram%. So indirectly question is asked what is the indication of blood transfusion. So whenever the hemoglobin level is less than 8, if it is less than 8 gram%, in that case we are supposed to go for blood transfusion, right? Okay, so this is the initial support. After that we have to start the drugs which are going to control the bleeding, and this is known as pharmacotherapy. So pharmacotherapy, which drugs are given? The drug of choice for controlling bleeding. The drug of choice for controlling esophageal varicose bleeding is octreotide. So it is octreotide. And what's the alternative? The alternative is terlipressin. It's the terlipressin plus nitrates. Simple. Now see, this is a controversial point. In CMDT, the drug of choice which is given in CMDT is terlipressin, and in Blumgart it is octreotide. Blumgart is the Bible of hepatobiliary pancreatic surgery, and we will go for octreotide. Why terlipressin is not drug of choice? Because it causes intense or severe vasoconstriction, and that's why in certain patients it can precipitate angina. To counteract this side effect, see which drug is given? Nitrates. So that's why the drug of choice is octreotide. Alternative is terlipressin plus nitrates. So bleeding is controlled. Now what's the problem in the patient? See, in the patient the stomach is having blood inside because of varicose bleeding. So what we had to do, we had to perform the lavage and we had to clear the stomach. So insert Ryle's tube, we insert Ryle's tube and perform the lavage. Now question is asked that for performing lavage, which saline is used? Room temperature saline or cold saline? So be careful, we are supposed to use the room temperature saline, because if you are using cold saline, use of cold saline can increase the risk of hypothermia. And if there is hypothermia, hypothermia leads to reversible coagulopathy. What is that? Because hypothermia causes reversible platelet dysfunction. So we have to perform the gastric lavage, and it is performed with room temperature saline. Room temperature saline. Cold saline should not be used. Why cold saline? Cold saline should not be used because it leads to hypothermia, and hypothermia causes reversible platelet dysfunction, so it can cause coagulopathy, which can further increase the risk of bleeding. Clear? So you perform the lavage. Now stomach is clear and patient is ready for the investigation. Which one? Endoscopy. So what is the first investigation done in any case of upper GI bleed? So the first investigation done in any case of upper GI bleeding is upper GI endoscopy, right? So what's the first investigation done in upper GI bleeding? Clear? And it's the endoscopy. Now what is the advantage? This endoscopy is both diagnostic and therapeutic. Why? Because in majority of cases you can control the bleeding by endoscopic varicose ligation or endoscopic sclerotherapy. So we have two options. We have endoscopic varicose ligation and we can go for endoscopic sclerotherapy. Clear? Which one is preferred? See, endoscopic varicose ligation is preferred over endoscopic sclerotherapy. Now see why. Endoscopic sclerotherapy is easy to perform, but what is the problem? Whenever we are injecting the sclerosing agent, there is no depth perception with endoscope. So whenever you are performing endoscopic sclerotherapy and there is no depth perception, what happens? Can you see? Your needle goes out. So when your needle goes out of esophagus, what you did esophageal perforation. So endoscopic sclerotherapy is easy to perform, but the risk of complication is higher. And which complication? Is the perforation. Endoscopic varicose ligation is a bit difficult to perform, but it is having lesser risk of complication. That's why it's preferred. So here you can see how this banding or varicose ligation is done. So I'm going to apply this band around this bleeding varices. So here you can see this is the band. So what? The bleeding is controlled. So here you can see how we are going to perform the endoscopic sclerotherapy. You can see that this is endoscope and this is the sclerotherapy needle. Can you see? So this needle is going to inject the sclerosing agent, and because of that there is sclerosis or fibrosis and bleeding is controlled, right? So which one is preferred? We discussed endoscopic varicose ligation is preferred over endoscopic sclerotherapy. So why? Because in endoscopic sclerotherapy there is increased risk of complication. Okay, and which complication we discussed? It's the esophageal perforation. Esophageal perforation. Okay, so bleeding is controlled. Generally we shift the patient into the ward and we start antibiotics. In all patients antibiotics are given minimum for 7 days. So we have to start antibiotics and it's given for 7 days. Clear? What is the advantage? First, if we are using the antibiotics, it is going to decrease the risk of infections, decreases the duration of hospitalization. It decreases duration of hospitalization and decreases the rebleeding risk. Rebleeding risk. Clear? So this is how we are going to manage. Now see a second situation. This question was asked in AIIMS. In a patient of esophageal varicose bleeding, endoscopic varicose ligation was done and patient was shifted to the ward. Within 24 hours, rebleeding occurred. What is the next best step? First, repeat endoscopy. And second, surgical intervention like TIPS or shunt. I'm repeating the question. In a patient of variceal bleeding, endoscopic variceal ligation was done. Bleeding was controlled. Patient was shifted to the ward. Within 24 hours, rebleeding occurred. What is the next best step? The next best step is repeat endoscopy. Why? Because what is the cause of rebleeding? At one point of time, 10 to 15 or 10 to 14 varices are there generally. So the varices which was controlled is not responsible for rebleeding. Usually it's some other varices which is responsible. So you have to perform repeat endoscopy. If 2 attempts of endoscopy are not able to control the bleeding, this is known as failed endoscopy, and then only we go for surgical intervention. So whenever there is rebleeding, we go for repeat endoscopy. Clear? And when endoscopy is failed, 2 attempts of endoscopy not able to control bleeding, then only we go for surgical intervention like TIPS or shunt. Clear? So this is how we manage. So this is a situation or description of tertiary care. Now imagine in rural areas where patients are taking desi liquor or desi daru, that is very dangerous, very strong alcohol, and patients are taking that. That's why they are very prone to develop cirrhosis, and if they are going to develop cirrhosis, they develop portal hypertension. Okay, so in rural area also you will find many patients of cirrhosis who develops portal hypertension. Because of portal hypertension there is variceal bleeding. Whenever there is variceal bleeding, the patient is shifted to PHC, primary health center, and there if expertise is not available, the doctor or compounder is going to insert a tube to control bleeding, so that when the patient is being transported to the tertiary care center, during transportation there is no bleeding. So we use a tube known as Sengstaken-Blakemore tube to control the bleeding, especially during transportation. So here you can see this is Sengstaken-Blakemore tube, in short called SB tube, Sengstaken-Blakemore tube. Here you can see how many balloons are there. One is gastric balloon, one is esophageal balloon. So this is double balloon, and how many lumen? 1, 2, 3. So triple lumen tube. What is this third lumen is for? 2 lumens are for balloons and one is for aspiration. So there is aspiration channel. Clear? So what this Sengstaken-Blakemore tube is? Double balloon, triple lumen tube. Double balloon, triple lumen tube. Okay, what is the use? It is mainly used for controlling bleeding during transportation. Now the problem, whenever these patients are brought to the emergency, they are in the state of shock, and the second problem, their stomach is full with the blood. So stomach is full and patient is in the state of shock. Or whenever we are attempting the insertion of this big bulky tube, Sengstaken-Blakemore tube, what's the problem? There is increased risk of aspiration. So the most common complication of insertion of this tube is aspiration. So what is the most common complication? And that's aspiration, right? So what should be protected before inserting the Sengstaken-Blakemore tube? Airway should be protected. So what? Airway should be protected. So protect the airway. Clear? After that, you are going to insert this tube. You are going to insert the tube, right? And after inserting the tube, first you are going to inflate this gastric balloon with 50 ml of air. Only air is used for inflation of balloon. Water saline contrast is contraindicated. Why? Because with air it's very easy to inflate the balloon and deflate the balloon. With liquids it's difficult to deflate the balloon. So what? Air is inserted for inflating the balloon. So whenever we insert the tube and we inflate the gastric balloon, after that, can you see I'm going to pull it. So when I'm going to pull the tube, what happens? The gastric balloon is going to be stuck at G junction. So when this gastric balloon is stuck at G junction, now I'm 100% sure that esophageal balloon is in the esophagus. Clear? And now I inflate the esophageal balloon. So first we put 50 ml and pull the tube. When the tube is stuck at G junction, the balloon is stuck. Then we further add 250 ml of air in gastric balloon. So total how much? 300 ml. Right? After that we start inflating which balloon? Esophageal balloon. Right? And after inflating the esophageal balloon, how much should be the maximum pressure? The maximum pressure exerted by the balloon should be 35 to 40 mmHg. Why? Because if pressure is more than 40, what happens? Perfusion stops and there is increased risk of ischemia and perforation. So the maximum pressure exerted by esophageal balloon, 35 to 40 mmHg. Third very important point, every 12 hourly you have to deflate the esophageal balloon. So deflate esophageal balloon every 12 hourly. Every 12 hourly we have to deflate the esophageal balloon. Why? To prevent the esophageal ischemia. So this is Sengsteken-Blakemore tube, which is double balloon triple lumen tube. For isolated gastric varices, we can use a single balloon tube, and that is known as Linton necklace tube, and the capacity of the balloon is 400 to 700 ml. So this is Linton necklace tube. So you can see how many balloons. Yes, there is a single balloon, that is gastric balloon, and it is having capacity of 400 to 700 ml, right? So this single balloon tube is used for isolated gastric varices. So this is used for isolated gastric varices. Clear? So these tubes are used to control bleeding during transportation. Once patient reached the tertiary care, right, we are supposed to manage the variceal bleeding as we discussed before. Next important topic is tips. It is asked in medicine, it is asked in surgery. Full form of tips: transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt. So first important point, it's a non-selective shunt. It's a non-selective shunt. Okay, so in this case we are supposed to insert the stent, and stent is inserted between right hepatic vein and right branch of portal vein. Which vein is used for cannulation? The preferred vein for cannulation is what? Right internal jugular vein. And for cannulation of portal vein, we use a needle known as Roche needle. So another very important point, right internal jugular vein is preferred for cannulation. For portal vein, we use Roche needle for cannulation. And what is the name of stent? Name of stent which is used? All these are questions. It is Viator. Clear? So it is very easy to understand. Tips, have a look. We are going to cannulate right internal jugular vein. So see, I cannulated this right internal jugular vein. Via this right internal jugular vein, I entered into superior vena cava. Via this superior vena cava, I am going into right atrium. Via this right atrium, I am entering into inferior vena cava. Right? Now see, this is the liver. Okay? This is the right hepatic vein. This is the middle hepatic vein. This is the left hepatic vein. And see, this is the right branch of portal vein. Clear? There is no direct communication between hepatic vein and portal vein. We are going to create a communication. So we are going to create a communication, and after creating the communication, we are going to insert what? The stent. Here you can see. So this stent has been inserted between right hepatic vein and right branch of portal vein. Now what will happen? Yes, in portal hypertension there is increased resistance to venous drainage, mainly the portal venous drainage. So here you can see, just after inserting the stent, you can see major amount of blood or almost whole portal blood starts going directly into IVC. Clear? Immediately the portal pressure comes down and most of the complications are going to improve, right? But the problem, see here, what is the role of liver? Liver is the site of urea synthesis. So here detoxification of ammonia occurs, ammonia is converted into urea. Now the portal blood, which is having high content of ammonia, so this high content of ammonia enters into systemic circulation, and if it enters into systemic circulation, what will happen? There is encephalopathy. So encephalopathy is the most common complication of what? TIPS. One problem. Second problem, you can see because of this stent insertion, the venous return to the heart is increased or decreased? Increased. So any condition in which there is already some load to the right heart, that will be the absolute contraindication to the TIPS. So here you can see this is the final diagram. This is the right hepatic vein and this is the right branch of portal vein, and you can see this is the stent inserted. Clear? So how the blood goes? The blood starts going like this. Simple. So first of all, what are the complications? We discussed complications of TIPS. Most common complication is encephalopathy. And what's the cause? It's because of ammonia. Encephalopathy, this is the most common because of ammonia entering systemic circulation. Other causes, there is stent stenosis or stent thrombosis. So it can occur, there can be stent stenosis and stent thrombosis. Clear? Now coming to the contraindications and indications. We discussed that venous return is increased. So any condition in which there is already load on the right side of heart, that will be an absolute contraindication, like right-sided heart failure, like pulmonary hypertension or hepatopulmonary syndrome. So what are the contraindications of TIPS? Contraindications. See the absolute contraindications and relative contraindications. Absolute and relative. Clear? So what are the absolute contraindications? First, right-sided heart failure. Second, pulmonary hypertension. Third, hepatopulmonary syndrome. And fourth, polycystic liver disease. Why? Because in polycystic liver disease, the anatomy is distorted, leading to increased risk of complications. Relative contraindications. First is portal vein thrombosis. Second, hypervascular liver tumors. Hypervascular liver tumors and encephalopathy. Clear? Now what are the indications? It's very easy to crack the questions related to indications. Any condition in which the portal pressure is increased, generally TIPS is going to help, right? Because it is going to decrease the portal pressure and obviously the complications are going to improve. So what are the indications? Indications of TIPS. So most common indication of TIPS is prevention of variceal rebleeding. Most common indication is the prevention of variceal rebleeding, right? And we discussed that if it's difficult to control acute variceal bleeding, by endoscopy, we can go for TIPS. So second indication, acute variceal bleeding. Refractory ascites, refractory hepatic hydrothorax, refractory ascites, refractory hepatic hydrothorax. Then very important, hepatorenal syndrome, hepatorenal syndrome, Budd-Chiari syndrome, veno-occlusive disease, and portal hypertensive gastropathy. Hepatorenal syndrome, Budd-Chiari syndrome, veno-occlusive disease, portal hypertensive gastropathy. Now one of the famous question of MC, which of the following is not an absolute contraindication of TIPS? So first option is right-sided heart failure, pulmonary hypertension, hepatorenal syndrome, and hypervascular liver tumor. So in exam, hepatorenal syndrome looks like hepatopulmonary syndrome, right? So be careful. Hepatorenal syndrome is an indication of TIPS, and hepatopulmonary syndrome is an absolute contraindication. Rest question you can easily crack, but here is the point where you do the mistake in exam. So hepatorenal syndrome is an indication and hepatopulmonary syndrome is an absolute contraindication of TIPS. Now we are going to discuss shunt. First see what are the types of shunt, then we will discuss in detail. So what are the types of shunt? Surgical shunt is of three types. One is non-selective, second is selective, and third is partial. So see the types. So first one is non-selective, second is selective, and third is partial. Okay. This non-selective shunt is further divided into first ec fistula, second is side to side portocaval shunt, SSPCS, side to side portocaval shunt, third interposition graft. This interposition graft is further divided into portocaval, mesocaval, and mesorenal. It is divided into portocaval, mesocaval, and mesorenal, right? And the fourth is PSRS. What is the full form of PSRS? Proximal splenorenal shunt, and it is also known as Linton's shunt. So this is proximal splenorenal shunt, also known as Linton's shunt, right? So these are the types of non-selective shunt. What is the meaning of non-selective shunt? In non-selective shunt, there is migration of almost whole blood of portal vein into systemic circulation. Almost whole blood. Selective shunt means selectively one particular region is being drained into systemic circulation. So what are the types of selective shunt? First is DSRS. DSRS full form distal splenorenal shunt. And who made this shunt for the first time? It was first made by Warren, and that's why it is also known as Warren shunt, right? Second is Inoguchi shunt. Inoguchi shunt. And what is partial shunt? Whenever the diameter of shunt is less than 10 mm, in that case there is only partial migration of blood flow. So when the stent diameter is less than, or shunt diameter is less than 10 mm, there is partial migration of blood flow, and that is known as partial shunt. So in this case, shunt with diameter less than 10 mm. Right? This is the classification. One by one we are going to discuss. First of all, ec fistula. So first is ec fistula. Ec fistula. Okay. So see how we are going to create this ec fistula. You can see this is the liver, right? And this black colored structure is inferior vena cava. This is IVC. And this blue colored structure is what? Portal vein. Okay. Now what I'm going to do in this case, I'm going to divide this portal vein here. So you're going to divide the portal vein, And after dividing portal vein, the proximal part of portal vein is sutured to side of IVC. So here this part is sutured to side of IVC. Clear? So what kind of anastomosis is there? You can see there is end to side portocaval shunt. So here this is end to side portocaval shunt. So this is also known as end to side portocaval shunt. Simple. Now what will happen? Here you can see that almost whole blood of the portal vein starts going to enter into IVC. Clear? And the portal pressure comes down. But the problem, you know that 75% blood supply of the liver is coming from portal vein, and here you divided the portal vein and almost whole blood is going into IVC. So what's the problem? Here the liver is going to develop ischemia. So in this patient, what's the problem? There is increased risk of hepatic ischemia. So because of this complication, what? This shunt is of historical importance only, not used nowadays. So it's of historical importance. It's obsolete. Why? Because of complications. Okay, so this is egg fistula. How to remember? This is end to side portocaval shunt. Second is side to side portocaval shunt. Okay, how we are going to create this side to side portocaval shunt? Again you can see this is the liver. This black colored structure is inferior vena cava, right? And this blue colored structure is the portal vein. This is the portal vein. Now what I'm going to do, side of portal vein is sutured to the side of IVC. So this is side to side portocaval shunt. How? You can see. So this is side of IVC. This is side of portal vein. This is sutured. So this is side of IVC and this is side of portal vein. Clear? So this is side to side portocaval shunt. Now what will happen here? You can see the blood will be going like this, the blood will be going like this, and the blood will be going like this. Okay, so you must be thinking that from which area or from which veins the blood is coming. From the upper part of portal vein. Here you can see this is left gastric vein. Yes, so whatever the left gastric vein is bringing into the portal vein, even that blood is also going into IVC. Clear? So this is side to side portocaval shunt, and this is most commonly performed shunt worldwide. So side to side portocaval shunt, this is most commonly performed shunt worldwide. Okay, and this is shunt of choice. It's the shunt of choice. In which conditions? First, Budd-Chiari syndrome. Second, veno-occlusive disease. And third, refractory ascites. Refractory ascites. Clear? So side to side portocaval shunt is most commonly performed worldwide, and it's the shunt of choice for Budd-Chiari syndrome, veno-occlusive disease, and refractory ascites. The third is interposition graft. Okay, so see, what is this interposition graft? Now it's very easy to understand. See, in side to side portocaval shunt, side of portal vein was sutured to side of IVC, but in interposition graft, what? There is one graft in between the two vessels. So I'm going to use a vascular graft in between the vessel. Clear? So this is interposition graft. See the diagram? So here you can see that this is liver. This black colored structure is inferior vena cava, and you must be knowing that on left side this inferior vena cava is giving one tributary, and that's known as left renal vein, right? Now see, this is the blue colored structure, and what's this blue colored structure? This is the portal vein, and this is the spleen. Clear? Now see, if I use the interposition graft between portal vein and vena cava, it is portocaval. The name is portocaval. If I use the interposition graft between superior mesenteric vein and vena cava, here superior mesenteric vein and vena cava, so this becomes mesocaval. And if I use the graph between superior mesenteric vein and renal vein, then it becomes mesorenal. So here you can see is the mesorenal. Clear? So how blood goes? See, this is how blood goes into the IVC. So you can see this is how blood goes into IVC, and here you can see this is how the blood goes in the IVC. Clear? So this is portocaval, mesocaval, mesorenal, and it's very easy to understand. The name is or term is self-explanatory. Portocaval means between portal vein and vena cava. Mesocaval means between superior mesenteric vein and vena cava. Mesorenal means between superior mesenteric vein and renal vein. Next is PSRS. We discussed full form, proximal splenorenal shunt, and it is also known as Linton's shunt. Linton's shunt. Clear? How we are going to create this shunt? See, this is liver, this is inferior vena cava. Clear? This is the tributary on the left side, and that is left renal vein. This is kidney, and this is the portal vein, and this is the spleen. Splenic vein, spleen, portal vein. Okay. Now see, sometimes the students are confused that which part is proximal, which part is distal. So any organ or any structure where it starts or begins, that is the proximal, and where it ends, that is the distal part. So see, splenic vein, proximal part is in the hilum where it starts, and the distal part where it is going to join with superior mesenteric vein and form portal vein. Clear? Now in PSRS, proximal splenorenal shunt, what we do, can you see, I'm going to divide this proximal part of the splenic vein, and after dividing this proximal part of splenic vein, you can see that I'm going to attach this splenic vein to which structure? To the renal vein, right? So if you're going to divide the venous drainage of spleen, obviously you have to perform splenectomy. So after performing splenectomy, I'm going to attach the proximal part of splenic vein to the renal vein. And what is the direction of blood flow here? You can see this is the direction of blood flow. Clear? So this is the direction of blood flow. So that's why it is known as what? Proximal splenorenal shunt. So in all these shunt, what you can make out, that almost whole blood of portal vein is entering into systemic circulation or IVC. That's why all these are the types of non-selective shunt. Now we are going to discuss the selective shunt, and in these shunts you will notice that one selected region will be drained into systemic circulation. First of all, it's the DSRS, distal splenorenal shunt. It is also known as Warren shunt. Clear? Other name is Warren shunt. Okay, see the diagram again, easy to understand. This is the liver, okay, this is the inferior vena cava, and on left side this is the tributary left renal vein, this is the kidney, this is the portal vein. Clear? This is the spleen. Here I'm going to divide this distal part. After dividing this distal part of splenic vein, what I'm going to do, can you see, I'm going to suture this distal part of splenic vein to the renal vein. And when I'm going to suture this, what is the direction of blood flow? You can see. Yes. So the blood from splenic vein is entering into systemic circulation. But if you see the blood of superior mesenteric vein, it is still going into portal vein and it is still going into the liver. So here a selected region is being drained, and that's why it is known as what? Selective shunt. So this is distal splenorenal shunt, also known as Warren shunt. Another selective shunt is Inoguchi shunt. It's the Inoguchi shunt. Clear? How to remember Inoguchi shunt? There is a mnemonic, and the mnemonic is IVC. IVC. I means this is interposition graft. Interposition graft. V means vena cava and C means coronary vein. Between vena cava, C means coronary vein. And you must be knowing that this coronary vein, it's the other name of left gastric vein. It's other name of left gastric vein, right? Now how we are going to create inocuity shunt? See this diagram. This is the liver, this is the inferior vena cava, this is the portal vein, and you know that here this left gastric vein is going to drain, and there is portosystemic anastomotic site between which two structure this left gastric vein, also known as coronary vein, and this is azygous vein. Clear? Azygous vein. Right? Now see, there is interposition graft between this left gastric vein, also known as coronary vein, and IVC. So what will happen? Yes, whatever the blood is here in this region, the blood starts going where? Into the IVC. So here you can see one selected region, means the G junction part is being drained into IVC. So that's why it is a type of selective shunt. And any shunt in which you are going to make the diameter less than 10 mm, there will be only partial migration of blood flow, and that is what? Partial shunt. Shunt is very important topic. It is frequently asked in exam. Sometimes image based questions are asked, especially in NEET and DNB. So tell me, what is the name of the shunt? Here you can see the splenic vein is divided and the proximal part is sutured to renal vein. So what is the name? This is selective shunt or non-selective shunt. So this is a type of non-selective shunt. And which one? This is proximal spleno-renal shunt. Clear? In this case, if you see here, the distal part of splenic vein is divided. Clear? And this distal part is sutured to its structure renal. So this is what? Distal spleno-renal shunt, and obviously this is a type of what? Selective shunt. Clear? These are the two most commonly asked image-based questions related to shunt. Another question which was asked in AIIMS and DNB, it was peritoneovenous shunt. The term is self-explanatory. See, surgery is not very difficult subject. Actually speaking, it's an easy subject. So if you are going to break down the terms, you can easily get the meaning. So the name of shunt is peritoneovenous shunt. It means one end should be in the peritoneal cavity and one end should be in the vein. So why we are creating a shunt between peritoneal cavity and vein? Because the patient is having refractory ascites. So that the ascitic fluid should be going directly into venous circulation. So what are the names of peritoneovenous shunt which are used? Peritoneovenous shunt. Okay. So first, the peritoneovenous shunt is made, or what is the indication? It is for refractory ascites. So this is used in refractory ascites. What are the names of shunt? Names you have to remember. The names are first Levine, Denver, Levine, Denver and Minnesota. So it's the Levine, Denver and Minnesota. Okay. Now it's very easy to understand. See, this is the peritoneal cavity. Okay. And this patient is having refractory ascites. Right. Now see, this is the vein. Which vein? Right internal jugular vein. And this right internal jugular vein drains into superior vena cava. Clear? What we do, we have to insert a shunt. Clear? One end in the peritoneal cavity, another end is in right internal jugular vein, that's preferred, or alternative is superior vena cava. Now see, there is unidirectional valve in this shunt. Clear? So there is presence of unidirectional valve, and that's why what will happen, this ascitic fluid will be entering into systemic circulation or venous circulation, but blood will not be able to come into the peritoneal cavity. Clear? So the question which was asked in AIIMS, that which vein is preferred in peritoneovenous shunt? So here the preferred vein is right internal jugular vein and the alternative is superior vena cava. So here you can see the diagrammatic representation. Can you see this shunt with multiple openings, and there is a valve, and here this ascitic fluid is going into this shunt and finally entering into right internal jugular vein or sometimes superior vena cava. Another important topic which is frequently asked in medicine and surgery, and that is non-cirrhotic portal hypertension. So see, non-cirrhotic non-cirrhotic portal hypertension. Clear? So if you break it into two parts, one part is non-cirrhotic and second part is portal hypertension. So if it is non-cirrhotic, it means there is no cirrhosis. No cirrhosis means no ascites, no jaundice, no encephalopathy, no hepatic failure. Right? Portal hypertension is there will be two universal manifestations of portal hypertension. What's that? One is variceal bleeding and second is what? Splenomegaly. Clear? What is the most common presentation? Right? Most common presentation will be variceal bleeding. And what is the most common cause of death? We discussed in cirrhosis, most common cause of death is hepatic failure. Here, there is no cirrhosis. So the most common presentation as well as the most common cause of death is variceal bleeding. Clear? So see, non-cirrhotic, it means in this patient, there is no cirrhosis. So, no ascites, no jaundice, no encephalopathy, no encephalopathy. Right? So signs and symptoms of hepatic failure are absent. Now see, there is portal hypertension. So two universal manifestations will be there. First what? There is variceal bleeding. So there is variceal bleeding and there will be presence of splenomegaly. Splenomegaly. Right? So what is the most common presentation and what is the most common cause of death? So the most common presentation as well as most common cause of death is what? Variceal bleeding. Simple. So what two conditions which are included in non-cirrhotic portal hypertension? The two conditions are one, EHPVO extrahepatic portal venous obstruction and second is NCPF. So this non-cirrhotic portal hypertension, it includes EHPVO and NCPF. Extrahepatic portal venous obstruction and NCPF. So what are the similarities? Yes, these are the similarities between EHPVO and NCPF. What? That in EHPVO and NCPF there is no cirrhosis, ascites, jaundice, encephalopathy, means no signs and symptoms of hepatic failure. What is the most common presentation in EHPVO and NCPF? Variceal bleeding. What is the most common cause of death? Variceal bleeding, and splenomegaly is present in both. The difference? In EHPVO, mild to moderate splenomegaly is present. It's in NCPF, moderate to severe splenomegaly. Right? Now see the differences. So if you see the differences, EHPVO and NCPF, right? Now break it. What is the full form of EHPVO? Extrahepatic. It means the obstruction is there in the portal vein, but this obstruction is outside the liver. Okay, see, this is the liver, this is the portal vein, right? This is the splenic vein, this is the superior mesenteric vein. Okay, what is the extent of portal vein outside the liver? This much portal vein is outside the liver. So the obstruction will be in this particular part only. So exactly where? You can see this is the first order branch and this is the second order branch. Where it bifurcates, the most common site is this one. And what's this? This is the confluence of splenic vein and superior mesenteric vein. So first question, what is the most common site of EHPVO? It's the confluence of splenic vein and superior mesenteric vein, means where portal vein begins. Generally it is going to involve first or second order branches, right? And it is seen in first to second decade. We discussed splenomegaly is there. What kind of? Mild to moderate. Splenomegaly is not very common, so splenomegaly, it's less common. Splenomegaly is less common. And what kind of? It's mild to moderate. Clear? Now see NCPF full form, non-cirrhotic portal fibrosis. So non-cirrhotic portal fibrosis means there is no cirrhosis but still there is portal fibrosis. Now in NCPF, it's the third and fourth order branches which are involved. So see, we discussed that this is first order branch, this is second order branch. Now see, this is the portal vein, the third bifurcation and fourth bifurcation. So this is third and this is the fourth. So here you can see that this is the third order branch and here this is fourth order branch. So in this case there is involvement of third and fourth order branches, and the age is towards higher side, means second to fourth decade. So first it is going to involve third to fourth order branches and generally seen in second to fourth decade. Right? The question which is asked in pathology also frequently as well as surgery, that there are three substances whose exposure increase the risk of NCPF, and the mnemonic is VAC. It's the VAC. So that's vinyl chloride. It's the vinyl chloride. A is the arsenic and C is the copper. Vinyl chloride, arsenic, copper. This increases the risk. The splenomegaly is moderate to severe and generally splenomegaly is more common. So in this case, splenomegaly is more common. It's more common and it's moderate to severe. Clear? Moderate to severe. So this is favorite topic of AIIMS, frequently asked both in medicine and surgery. Two other topics which are frequently asked in medicine and surgery, one is Budd-Chiari syndrome and one is veno-occlusive disease. So first we are going to discuss Budd-Chiari syndrome. Okay, what happens in Budd-Chiari syndrome? It is characterized by hepatic venous outflow obstruction. And this hepatic venous outflow obstruction can be because of two things: either there is hepatic vein thrombosis or there is IVC obstruction, or both. So it is characterized by hepatic venous outflow obstruction. Okay, in majority of cases it is because of hepatic vein thrombosis. And what's the most common etiology of hepatic vein thrombosis? Is the polycythemia vera. Okay, so overall most common cause is hepatic vein thrombosis and the most common etiology of hepatic vein thrombosis is polycythemia vera. Why? Because polycythemia vera increases the risk of hypercoagulability and hypercoagulability increases the risk of venous thrombosis. Okay, second is IVC obstruction, right? IVC obstruction is the most common cause of Budd-Chiari syndrome in certain countries. Which countries? It is the most common cause in India, China, Japan and South Africa. India, China, Japan and South Africa. So IVC obstruction is the most common cause in these countries. Now what is the basic concept? See, it's very easy to understand. Suppose any organ is there. In that organ there is arterial inflow. So blood is coming to the organ but there is no venous outflow. Okay, so any organ in which there is no venous drainage or venous outflow, what will happen? That organ will be congested with the blood, and if organ will be congested with the blood, what will happen? There will be tender congestive hepatomegaly. And over a period of time, what will happen? There will be coagulative necrosis. So initially there is tender congestive hepatomegaly and then there is coagulative necrosis, and you will notice over a period of time what will happen? There will be atrophy of the liver. Clear? So same will happen in this case also. What happens? Initially patient is having tender congestive hepatomegaly followed by coagulative necrosis and later atrophy. So the patient will be having signs and symptoms of hepatic failure. So initially there is abdominal pain. Later patient is going to develop what? Anorexia, fatigue, ascites, jaundice, encephalopathy. Now suppose this Budd-Chiari syndrome is because of hepatic vein thrombosis. What happens? Almost whole liver is affected, but one lobe is spared. Which one? Caudate lobe. Why? Because caudate lobe drains directly into IVC. So over a period of time, liver is atrophied, but what will happen to caudate lobe? It is hypertrophied, and this hypertrophied caudate lobe on scintigraphy is known as what? Central hotspot sign, right? There is a new question which was asked about this condition, that what's the triad? What's the triad of Budd-Chiari syndrome? So see clinical features. It is characterized by a mnemonic, that's ASHA. So this is the triad, that's ascites, hepatomegaly, ascites, hepatomegaly, and abdominal pain. Clear? So this is the triad, ASHA. You have to remember. By the way, what are the other symptoms? So the patient is having abdominal pain. The patient develops ascites, jaundice, encephalopathy. There is anorexia and fatigue. So there is anorexia and fatigue. Clear? Suppose this patient is having Budd-Chiari syndrome because of hepatic vein thrombosis. So in patients of hepatic vein thrombosis, what will happen? Caudate lobe is spared, right? So caudate lobe, it is spared. And what happens? The liver is atrophied, but the caudate lobe is hypertrophied. So here, liver, there is atrophy, but what will happen? In caudate lobe, there is hypertrophy. Clear? And this hypertrophied caudate lobe on scintigraphy appears as, or it is known as, central hotspot sign. So there is central hotspot sign. Now what is the investigation of choice for diagnosis? See, where is the pathology? Pathology is in the hepatic vein, right? So what is the investigation of choice? Venography. And if pathology is there in the vena cava, it's vena cavography. Diagnosis. So investigation of choice for diagnosis depends on the etiology. So it is either venography or vena cavography. Vena cavography. Clear? Whenever we are performing venography, if there is hepatic vein thrombosis, there is formation of collaterals. And what kind of collaterals are seen on venography? It is spider web collaterals. So on venography, there is spider web collaterals. Okay. There is another question asked in surgery related to collaterals, and that is in Burgess disease. In Burgess disease, there is thromboangiitis obliterans. So what is the problem? There is arterial occlusion, and that's why investigation of choice is angiography, because artery is involved. And in that case, what kind of collaterals are seen? Corkscrew collaterals. So in Burgess disease, investigation of choice for diagnosis is angiography. And what kind of collaterals? It's the corkscrew collaterals, right? So these are the two questions which are frequently asked about collaterals. In Budd-Chiari syndrome, on venography, there is spider web collaterals, and in Burgess disease on angiography, there is corkscrew collaterals, right? Now see, the patient is having hepatic vein thrombosis, and any patient who is having venous thrombosis who is coming to our emergency within window period. For this condition, the window period is up to 3 weeks. So if patient is coming within 3 weeks, means within 2 to 3 weeks, we can easily attempt what? Thrombolysis. And we should start what? Anticoagulants. So management. If patient comes within 2 to 3 weeks, that's a window period. In that case, thrombolysis. And in patients of venous thrombosis, we have to start what? Anticoagulants. But what's the problem? Majority of patients are coming after window period, and in that case, see the situation. If patient comes after window period and this patient is having, see, this is IVC, this is hepatic vein, and this patient is having hepatic vein thrombosis. Clear? This is IVC. So what I'm left with, yes, hepatic vein thrombosis is there, so I will create a communication between this portal vein and vena cava. What kind of shunt I will create? Side to side portocaval shunt. So if the patient is having hepatic vein thrombosis, the preferred shunt is side to side portocaval shunt. One. Second situation, certain patients are having IVC obstruction. Sometimes there is a web, sometimes there is stenosis. So see, this is liver. This patient is having web or stenosis. This is the right atrium. Now see, here there is a web. So what I'm going to do, I'm going to perform thoracotomy and I'm going to open the right atrium. After opening this right atrium, what I'm going to do, I'm going to perform, or I'm going to rupture this web or membrane. So I'm going to rupture the membrane via heart, means via transcardiac route, and that's why the name of this condition or the name of this option is transcardiac membranotomy. So one option we have is transcardiac membranotomy. Okay, if there is thin membrane. Now imagine if this patient is having severe stenosis here. There is severe stenosis. In that case, what? The affected segment should be excised and grafting is done. So here I'm going to do what? This part. Yes, this is excised and I'm going for what? Grafting. So if there is IVC stenosis, in that case, excision and grafting. Excision and grafting. Clear? There is a third situation where both are seen. There is hepatic vein thrombosis also and IVC obstruction also. So see, this is the liver. This is the inferior vena cava. This is the portal vein. This patient is having hepatic vein thrombosis. Clear? So because of that, what I did, I created this shunt, side to side portocaval shunt. But what I noticed that in IVC also there is obstruction. So if in IVC also there is obstruction, so what I'm going to do, this is heart. Clear? So suppose here is the obstruction. So I'm going to use another shunt. Yes, between this part of vena cava and atrium, right atrium. So what's the name? This is known as, what's the name? This is known as cavoatrial shunt. What is the name? This is SSPCS, side to side portocaval shunt. So if patient is having hepatic vein thrombosis plus IVC obstruction, we have one of the option available, and that is side to side portocaval shunt plus cavoatrial shunt. Clear? And some patients are coming to us with hepatic failure, and if the patient is already having hepatic failure, in that case we have to go for liver transplantation. So if the patient is having hepatic failure, and then we go for liver transplantation. So this is how we manage the patients of Budd-Chiari syndrome. The next condition is veno-occlusive disease. Veno-occlusive disease. Okay, this is similar to Budd-Chiari syndrome. What is the similarity? That in this condition also there is hepatic venous outflow obstruction. What's the difference? Site of occlusion is different. Okay, so here it is characterized by hepatic venous outflow obstruction. Okay, but here what's the problem? In this case, it is because of endothelial sclerosis in hepatic vein or venules. So, because of endothelial sclerosis. Endothelial sclerosis. In which structures? Hepatic venules or sublobular hepatic vein. Sublobular hepatic vein. It means in the microscopic structure, these microscopic changes are seen. In Budd-Chiari syndrome, the pathology or the problem was in hepatic vein or vena cava. So that's why there we were going for venography or vena cavography. Here we want to see the endothelial sclerosis in venules or sublobular hepatic vein. So here investigation of choice for diagnosis will be what? Biopsy. The clinical features will be very similar, but etiology is a bit different here. So see, what's the etiology? Most common cause in Western countries. This was asked many times. In Western countries. Okay, and in Western countries, the most common cause is bone marrow transplantation. This was asked many times. Bone marrow transplantation. This is the most common cause in Western countries. Apart from this, use of immunosuppressive agents, chemotherapy also increase the risk. So, chemotherapy agents like cytarabine, thioguanine, gemtuzumab and ozogamicin. Gemtuzumab and ozogamicin. Clear? How to remember? The mnemonic is CTGO. CTGO. Okay. Then immunosuppressive agents. Immunosuppressants like azathioprine. Okay. One question which is asked frequently, that is consumption of bush teas. This question was indirectly asked in PSM also, that in bush tea which alkaloid is responsible for VOD. There is presence of pyrrolizidine alkaloid, pyrrolizidine, and this alkaloid pyrrolizidine is responsible. So consumption of bush tea. Which plant species are included? Crotalaria and Senecio. Clear? And there is presence of alkaloid. What's the name? It's pyrrolizidine. So alkaloid is pyrrolizidine. So these are the factors which are going to increase the risk of VOD, veno-occlusive disease. Here the triad is a bit different. Symptoms are similar, but the triad of VOD is a bit different, and the mnemonic is THR. Now see the clinical features. The triad is THR. Okay. T means tender hepatomegaly, H means hyperbilirubinemia, R means retention of fluid. So T, tender hepatomegaly, H means hyperbilirubinemia or jaundice, hyperbilirubinemia or jaundice, R means retention of fluid. Okay. So generally in this case also, since there is hepatic venous outflow obstruction, what are the symptoms? Patient will be having abdominal pain, there is ascites, jaundice, encephalopathy, there is anorexia and fatigue. We discussed that here the investigation of choice for diagnosis is biopsy, because we want to see endothelial sclerosis. So diagnosis, investigation of choice for diagnosis is biopsy. Now coming to the treatment. Here treatment is a bit easier. Why? Because here IVC is patent. So see, IVC is patent, that's why which shunt is performed. So what's the good thing about this condition is that IVC is patent. So what is the treatment option? SSPCS. So which shunt we are going to make in this case? Side to side portocaval shunt. And if the patient is having hepatic failure, so if the patient is having hepatic failure, in that case we go for liver transplantation, right? There is a question asked about a drug known as defibrotide, which improves the survival in VOD. So the name is defibrotide. So it's defibrotide, and this defibrotide improves the survival in VOD. This is veno-occlusive disease, and this is all about portal hypertension.